Thank you so much for giving me this opportunity to present today. The title of my talk today is Every Child Counts, Global Epidemiology of Childhood Infectious Diseases. Now, childhood infectious diseases really encompass a large number of infectious diseases, but I'm going to focus my efforts mainly on the ones which have the largest global burden. So I'm hoping by the end of this presentation, you will be able to define what the global burden of disease is, the concept really, identify some of the childhood infectious diseases with the largest global burden, describe the epidemiology as well as prevention and control efforts globally for some of these major childhood diseases. And specifically, I will be talking about acute respiratory infections, diarrheal diseases, measles, HIV, and malaria. These are the major childhood killers. So how many of you know what the Millennium Development Goal 4 states? So in 2000, the world leaders came together and came up with the Millennium Declaration and tried to adopt it and ratify it. And the purpose was really with the intent to invest more in development and to reduce poverty and disease. And so and while there are many goals, there are 8 major goals in the Millennium Declaration. The goal number 4 very clearly states to reduce by 2/3 under 5 mortality. So the next few slides and this presentation is really to see whether we have or are on our way to achieving this Millennium Development Goal. So can we really achieve MDG 4? And if you look at this graph, you will see that if what you really need to do to achieve that in 2015 is going to take a lot more than what we have achieved right now. So in 2013, so does anyone know what the rates of child mortality are today? Under 5 mortality. Just make a rough guess if you want to. Okay, so in 1990, we were at around 90 per 1,000 live births. Today we are at 46 per 1,000 live births. Those are the 2013 rates. And when you think in terms of child mortality, in terms of the number of children that are dying today, can anyone guess how many children die in a year worldwide? No. How many did he say? He's getting close. So let's imagine every child from the state of every child under 5 from the state of California, Texas, New York, and Florida not being there. So that many children die every year. 6.3 million children die every year. So for us to reduce those rates by 2/3 would mean you have to come down to about 2 million, right? Rather to 3, it would be like 3 million, 3.5 million. That's going to be really hard to do. So we are at 6.3 million right now, and we have 2 more years to go. So I wanted us to not forget that medical statistics are very important, and as Rudolf Virchow says, they should be our standard of measurement. We will weigh life for life to see whether dead lie thicker among the workers or among the privileged. So let's look at what we mean by global burden of disease. So how do we define global burden of disease? Basically, it's a way to calculate premature mortality as well as disability. So you want morbidity as well as mortality. So when in 1990, Christopher Murray from the Harvard group and Alan Lopez, who was part of WHO, now they've moved on to other institutions, but they came together to try to define the global burden of disease, because how do you focus your efforts when you are trying to reduce any kind of diseases? So the concept was, let's find a summary measure. So what the concept that they came up with was trying to compute both mortality as well as morbidity. So Basically, it's a summary measure. It's very complicated when you have to do the calculations. But I think what is important for us to know is that it's a summary measure, and it computes both years of life lost as well as years of life lived with disability. Because if we forget about living with disability, it's a huge burden that most of us sometimes forget also exists. And let's look at infectious disease. If you look at what the global burden was in 1990, it was 822 million dailies. It's come down significantly by over 200 million dailies, but it's still a very huge burden. So infectious diseases have not gone away. And when you look at these numbers, you will see that children are affected greatly. So let's look at what the global dailies were by cause. So if you look at 2010 and look at 1990, while some of those infectious diseases are in a lower order right now, so they're ranked a little lower. But if you look, lower respiratory infections are still number 2. Diarrheal diseases are still at 4. HIV/AIDS has gone up significantly to number 5, and malaria is at 7. So we still have, it's been consistent. And we still, if you see, the major infectious disease killers for children are still pretty high up there. Now when you look at it by age, sex, and cause, and you see on the left side you have, this is for males, and the females are on the right. And you will see, if you will see, I don't have anything right now, but you'll see many of the infectious diseases like diarrhea and all take up a significant global burden of disease. Malaria has been clubbed with neglected tropical diseases, but really malaria has the largest burden, the lilac one. And then you have HIV down there, the really dark yellow. So childhood infectious diseases cause about 40% of child deaths, under 5 deaths. And when you look at neonatal deaths, they cause about 23% of neonatal deaths. So among children under 5, the most important diseases are, again, as we talked about, acute respiratory infections, diarrheal diseases, malaria, and HIV/AIDS. And among neonatal deaths, we have sepsis, which is at 15%. And then again, you have pneumonia, diarrhea, and tetanus, which is about 18%. Does this mean that we've not had any decrease at all? Well, if you look at with all the prevention efforts and control efforts that have gone on, there has been a big decline in child mortality due to infectious diseases, although they have not gone away. And you can see over time that pneumonia has decreased by 44%, diarrhea by 54%, malaria, there's been a 40% decline. With measles and AIDS, measles was very high, 80% decline, and AIDS was 50% decline. One of the reasons why measles declined as much with the measles vaccine was because they focused a lot of their efforts in Africa. There was a large decline in Africa, but China is the one that really brought the rates down. So when they reduced, because it has such a large population, when you have a large population that reduces the number of children that die due to measles, it brings down the decline significantly all over the world. So we just talked about how there are over 6.3 million children that are still dying, and which means about 17,000 children die every year. But we have reduced it by almost 50%. It's been a big success story. In 20 years, from 1990 to now 2013, we are down to 6.3 million. We would love to be way below that, but it is going to take a little more. Now, there are some countries that will reach that goal of reducing it by 2/3, but not worldwide. That is something that is probably not going to happen. So currently, the child mortality rate is at 46 per 1,000 live births. Most of the child deaths, I mean, a large majority, 42%, are among neonatal. And if you look at the countries that account for the largest burden are India, Nigeria, the Democratic Republic of Congo, Pakistan, and China, which account for almost 50% of child under 5 deaths. We've also seen that pneumonia, diarrhea, and malaria account for about 33% of the deaths. And if you look at infant mortality rates, you will see that they range from 2 in Singapore to about 92 in the Central African Republic, and the same in under 5 mortality rate will be 2 in Singapore and as well as in some of the Scandinavian countries, and go up to 152 per thousand live births in Guinea. This is the global distribution of neonatal deaths in 2013. You'll see sepsis, pneumonia, tetanus, and diarrhea, the big infectious diseases, causes of infectious diseases. So we were talking right now worldwide. The continent that is affected the most by these child deaths is sub-Saharan Africa. And if you look at sub-Saharan Africa, you will see even when it comes to infectious diseases, they have the largest burden there. So you will see that 90% of all malaria and HIV deaths occur in sub-Saharan Africa. A third of measles deaths occur there, as well as more than 40% of pneumonia and diarrhea deaths occur in sub-Saharan Africa. So although there are only 50% overall of child deaths, but for certain infectious diseases, they account for a larger burden. So these estimates are really staggering when you look at them. So let's start looking at the first infectious disease, and we're going to talk a little bit about lower respiratory tract infections. So it's the leading killer in children less than 5. It's mainly pneumonia, mostly pneumonia, and they have found 4 pathogens that are responsible for pneumonia. You have Streptococcus pneumoniae, Haemophilus influenzae type B, RSV, and Pneumocystis jirovecii in HIV-positive children. And if you look at pneumonia has kills about 900,000 children every year. And in 2013, those were the estimates we have. While the number of dailies has decreased considerably, almost to half, but it is still a big killer. And most of the risk factors are what we all typically know. It's low birth weight, malnutrition. Aged children that are younger, less than a year, are more likely to die of pneumonia than children that are over a year old. Overcrowding, indoor air pollution, and lack of access to appropriate vaccines. We have very good vaccines right now for streptococcal pneumonia as well as the HIV vaccine, but both are not being used as they should be. Here are some pictures. They found that because of indoor air pollution, in many countries, you probably do not have the luxury of having stovetops like we do, so maybe outdoor cooking can make a little bit of a difference, and they found that some simple interventions like these can impact child mortality and morbidity rates. And there was one study that randomized a trial that was done looking at both traditional open fire. This was in Guatemala. It was called the Respire trial, and they found that there was a decrease in severe pneumonia for households that used a chimney stovetop. But if you look at that, there's a little bit of difference in terms of the particulate matter that it reduced was just 50%, from 2.2 million to 1.2 parts per million. So while it didn't achieve as much decrease in overall rates of pneumonia, in severe pneumonia, a third of it was reduced. So the authors concluded that you probably need more cleaner fuels rather than just using an intervention like this. While it would help, you would need better, cleaner fuels. Other ways of preventing acute respiratory infections are the vaccines. Even the measles vaccine has been found to prevent pneumonia, because if you see, many of these are linked, and we'll see that over time, over the next few slides, how all of these different childhood infectious diseases have more or less the same risk factors. Hand washing has been very, very clearly shown that it can reduce pneumonia in 50% of children under 5, and they've done a study which showed that, as well as reducing diarrhea as well in children less than 15 years of age. Clean fuels, supplementing with zinc, iron, and folic acid, as well as exclusive 6-month breastfeeding has been found to help in preventing acute respiratory infection. There were some other studies that showed that training community health workers makes a huge difference, because they found that community health workers that were trained were better at diagnosing as well as treating ARIs compared to those who are not trained. And another study that found that the way people describe ARIs is also very important, will be dependent on how they come for treatment. For example, they found in one study that in Africa, where mothers would rate the ARIs differently. Like some would call it supernatural, some would think of it as natural, some would think in terms of whether it was TB. So there were different ways that they would describe ARIs, and based on the way they would describe it, they would seek intervention. So if it was supernatural, they were going to use more traditional intervention. So you need to know what language people use when they describe an infection. One other study also found that pulse oximetry was very important. So providing pulse oximetry as well as oxygen source was important in terms of reducing pneumonia as well. So here are some pictures. This was where the study was done, providing soap. This was a hand washing promotion as well as plain soap in one arm, and then providing hand washing promotion as well as soap with antibacterial content. And they found just plain soap with the hand washing promotion made a huge difference in reducing both pneumonia as well as diarrhea. This is breastfeeding in a community. This is another intervention where they weigh the baby. The next section we'll talk about is diarrheal diseases. Diarrheal diseases are the second leading cause of child mortality. We have over 760,000 children that die of diarrheal diseases, which is more than 10% of all child deaths under 5. While the dailies again have decreased tremendously, if you see, there are still 4 major pathogens that account. So this global enteric study that was done, multi-site study that they did, showed 4 pathogens that cause the majority of diarrheal infections. And those were rotavirus, Cryptosporidium parvum, Shigella, and then enterotoxigenic E. coli. One of the biggest impacts of diarrheal diseases are that it impacts child's growth. So you will see children that are stunted and are malnutritioned and malnourished as well, because of which. The highest risk is between the ages of 6 to 11 months. And we all know most of the risk factors: poor sanitation and hygiene, malnutrition, as well as lack of breastfeeding of infants, as well as exclusive breastfeeding. And you will see that this is a recurrent pattern in many of the infectious diseases. Here are children that are exposed to water that is unsafe. And this is a child in the DRC that was suffering from diarrhea and was being provided intravenous fluids. Here in India, ORS, as we all know, is a life-saving intervention for children with diarrhea. And in many of the countries, for example, in India, they have pictures like this that you will find in the primary healthcare center to show people using 5 glasses of water, which are roughly about 200 ml each. So for 1 liter of water, you add the sachet for ORS in it, and then spoonfuls are fed to the baby. So this is the ORS formulation currently that is being used. So rotavirus is the major killer in the diarrheal diseases. And if you look at rotavirus, it kills almost 500,000 children every year. So which is a huge number. And again, the dailies have no doubt have decreased in 20 years. But it still accounts for a large burden of childhood infectious diseases. There are 5 serotypes that most of you are aware of that cause rotavirus infections. Children 6 months to 2 years are at greatest risk, and the studies have found that there is no real effect of hand washing and safe drinking water on rotavirus. So the rotavirus vaccine has been extremely beneficial. And right now, unfortunately, only 69 countries of countries that are Gavi eligible are really using the rotavirus vaccine in their national immunization program. In the United States, there were studies that found that the rotavirus vaccine can have benefits not only for the child in preventing severe diarrhea as well as hospitalizations, but also among family members. So it could be other children as well as adult members. So they found a large decrease in hospitalizations in 2008 after the rotavirus vaccine was manufactured, was available in the US. And there was one model that found that the rotavirus vaccine can actually prevent, in Gavi-eligible countries, more than 180,000 deaths, greater than 6 million clinic and hospital visits, and save over 68 million in treatment costs. The other disease that I wanted to talk a little bit about is cholera, because it still has a large impact, and the burden right now is estimated at about 45,000 deaths for children. But one of the reasons that I also chose to talk a little bit more about cholera is because there continues to be a lot of outbreaks of cholera even now. For example, we have a recent outbreak right now in Ghana, and it's so quickly spread from, as most of you know, Haiti, that never had any cholera, had such a huge outbreak, and it is now endemic. So it's an infectious disease that we have to watch that might become into a major killer of children if we don't continue preventing and controlling it. And we have a very good, we have 2 cholera vaccines that are available for children, and they're mostly given during outbreaks to prevent cholera, as well as there's a new rapid diagnostic test, but which is generally recommended only during outbreaks rather than for individual patients. Because of the sensitivity and specificity of the test is not very good. The test is manufactured recently in India. It was developed in India and was found to be very valuable for outbreaks. So some of the control issues that are most important for cholera are timely case management, improvements in water sanitation and hygiene, as well as health education. Food hygiene, food preparation is very important. As we all know, food preparation and food hygiene is not very good in most developing countries. And using oral cholera vaccine in high-risk areas or during outbreaks. The treatment is, again, ORS is very important, and then you have antibiotics like ciprofloxacin and azithromycin. I wanted to show you this slide because it kind of tells you how cholera has moved. So in the 6th pandemic in the 50s, it was mainly in South Asia. And in the 7th pandemic also, it started, it was mainly again in South Asia. And then it started going into Africa and then went into the Americas. So now you see towards the 90s, it has gone into all different parts of the world. So this was a really neat map which showed how the Haiti outbreak took place, and if you can see the clusters near the water sources. So just to briefly tell you, because these are the 2 larger, the major killers of childhood among children, at one time we had only a plan for pneumonia, because pneumonia was considered the most important killer for children. But they realized that because the risk factors are so common, so they decided to now come up with a plan which includes both pneumonia as well as diarrhea. So you now have a global action plan to prevent pneumonia as well as diarrhea. One would think that you would have thought of this earlier because they are the 2 major killers, and because the risk factors are so common to each other and they're all integral. But I think one of the biggest difficulties the world has faced is to figure out where do you focus your efforts. And it's all got to do with evidence and people trying to build research to prove that things work better if you provide integrated services. And so it has taken them several decades to come to the conclusion that we now need to have a lot of integrated services. So the basic focus of this plan was really to protect, prevent, and treat. And you can see in this slide the different ways they show the community health workers in the plan how you can protect, prevent, as well as treat. So you have vitamin A supplementation, vaccination for rotavirus, safe water and improved sanitation, as well as ORS, the low osmolarity ORS, and providing zinc and continued feeding for diarrhea. But those can also work for pneumonia as well and are important. Then you have, again, vaccination for pneumonia, reduced household air pollution, things we've already talked about, antibiotics for pneumonia, as well as oxygen therapy. One of the other things they found was when you looked, there was a systematic review that was done, and they found that if you increase the number of interventions sequentially, the number of deaths that can be averted can be very high. So if you just start with one intervention for dysentery, you will find that the number of deaths it prevents is really limited, probably 1,000 or, But when you start increasing the number of interventions and you total up all those interventions, you can avert almost over 300,000 deaths. So the next big killer of children is measles. So other than it being one of the leading causes of child mortality, it has significant morbidity as well. When you look at measles, there are serious complications that can occur, including blindness, encephalitis, pneumonia, ear infections, and diarrhea, which again start the whole cycle of malnutrition, as well as children are immunocompromised, so they can catch other infections. And the number of cases of measles are very high. And if you look at the world map today, we have measles even in Europe and in the US. We had a major outbreak in New York City last year. So it is still prevalent, and most of you are already aware of the reasons, because if there's no herd immunity, if not everyone is vaccinated, and we all know the many reasons that people are still not vaccinating in the United States. I think we've had these discussions in the past. So we continue to have these outbreaks. While measles did really well, the measles vaccination did really well, there was a resurgence in Africa in 2009. And part of the reason was that the vaccination levels came down, and there was not enough funding, and people might have not been also reporting the right numbers for vaccinations. So if people are not really immunizing at the level that they are supposed to immunize, and are accounting for higher numbers than they really are, so you can have some of these outbreaks as well. So they found that was also one of the reasons. And it typically happens that when you reach a point where your immunization levels are very high, people start reducing funding, because you now focus on another infectious disease or another disease, and that's exactly what happened with measles. So sustained funding is very important for many of these childhood infectious diseases. And if you look at the prevention and control for measles, we all know providing the MMR vaccine has made a huge difference to child mortality. Also giving vitamin A to prevent blindness and mortality is a big intervention that is used. We've seen that also in the other interventions that were available for pneumonia and diarrhea. And if you look at, because of this resurgence, it's really unfortunate that they started again immunizing. Till 2012, they had very good rates, and now in 2013, there is another a rise in the number of measles cases worldwide. So as a result, they have come up with a new plan, the Global Measles and Rubella Strategic Plan, really to focus and figure out the best ways to reduce these rates. And so providing second opportunity immunization is very important, just not routine immunizations, are also find every opportunity that you can immunize children. Effective surveillance, not very good surveillance systems in most parts of Africa and also Southeast Asia and South Asia. And rapid response to outbreaks is very important so that you are able to find out exactly how those outbreaks have taken place and managing those quickly. And communicating with people to build confidence, as well as a lot of funding for research and development to find out what is most cost effective and what will improve vaccination. So if you see, as the measles vaccine uptake increased, the number of cases decreased, but you will also see that what estimates the countries are giving, while what estimates WHO and UNICEF are, they are about 5 to 7% less than what the official estimates are. So it's roughly around 83%, which is not still a very good coverage for measles. Here is a child in a temple being immunized. This is in Nepal, where they go in the mountainous regions from door to door, immunizing children. I'm quickly going to talk about polio only because I have found that it's a good I think it's a good example for how infectious diseases can be eradicated, at least some of them, which are much easier to eradicate. And one of the reasons that polio eradication was possible is because you can provide oral polio vaccine. And polio virus only affects humans. There is no other reservoir, and so that it makes it easier to prevent polio. The oral polio vaccine is also very inexpensive. It's very easy to administer, so that was one of the reasons that it decreased. They were able to control it so quickly. But what is interesting is that there has been a fluctuation in the number of cases. So you've been having cases where the reduction was, if you see in 2012, there were 223 cases, and now in 2013, they went up to 416. They've come down right now, 279, but they probably will be another few more cases in December. So while 80% of the world's population lives in polio-free regions, it's been eliminated in most of the countries. And India is one of the countries that eliminated polio, which was the biggest challenge. They accounted for, India and Nigeria accounted for the majority of cases a few years ago, but India managed to control it, and it has been eliminated, and it's been officially given the certificate of elimination by the WHO. So, it is a disease, and we'll talk a little bit about how that was done also. So here are, in 2014, these are the number of cases we still have. Nigeria is still one of the places where we have a problem, and Afghanistan and Pakistan are the other countries that have poliovirus still being transmitted. So here is door-to-door vaccination for polio. Now this is a very telling scene in Pakistan. As many of you might have heard already, that in the time when they were trying to search for Osama bin Laden, the CIA used vaccination, the immunization campaign, as a way to find out information about him and to try to get DNA testing by trying to provide vaccines to people in these communities. And as a result, it backfired. So a lot of health workers that were providing the vaccine were killed. So as a result, you now have, because Pakistan is still one of the countries which has polio transmission, they now have security for the polio workers. When the health workers go around providing polio vaccine, they actually have somebody there to make sure that they're secure. So this is the motto for polio. So in India, it was very interesting the way they tried to reduce polio and eliminate it completely, because there are a lot of migrant populations as well. So they would wait at train stations and provide the vaccine. And one of the things they did was, finger marking is one thing that they use in many countries that do not have an effective way of monitoring which children have received polio or not. So when you provide finger marking, you know when a child has received polio or not. They did house marking if children had not received, and the house marking would actually tell you why the child, based on how the house was marked, they would tell you how why the child had not received the polio vaccine, and the intervention would be targeted based on that. For example, if a parent refused because the child was sick, they would have a physician go to that home and try to talk to the parent and reassure them. or if it was because they refused the vaccine for some other reason, then a community health worker would go and talk with them. So they had different strategies to be able to complete vaccination. So because they have not been completely able to eradicate polio, there is a new plan that has come out to make sure that in the next few years they will try to eradicate it completely. And so the plan is more detailed and developed, and you can go over that when you have a little bit of time. I'll quickly go over pertussis because pertussis is a very difficult disease to really, to have good surveillance data. And so there's really not much information. These are all estimated cases that CDC has come up with, where they estimate that between 30 to 50 million cases of pertussis occur in the world. And there are roughly about 89,000 deaths that were estimated in 2008, which is a significant burden as well. In the US itself, we had over 28,000 cases in 2013. And part of the reason, again, we know is because of lack of vaccination, as well as the acellular vaccine has its also challenges in not preventing. So you could, despite vaccination, also get pertussis. So this was a neat graph which shows you how after the after DTP and then DTaP and Tdap, you see the decrease in the number of cases in the United States from 1922. And now we've had these outbreaks recently. The last two diseases that I am going to talk about are malaria and HIV, because they are, again, have a huge burden, not probably as huge a burden as ARIs and diarrheal diseases, but still a significant burden. So again, malaria, all of you know, is caused by 4 parasite species. And then we have, it is the only disease where the dailies have gone up. So the global burden has increased rather than decreased. There are 1 in 5 child deaths in Africa because of malaria. So that roughly amounts to about 482,000 deaths only in Africa. What is unfortunate is malaria also has an impact in terms of morbidity, because children, 3 to 15% of children can have some residual neurological complications. Other complications are chronic anemia, which is a huge issue again, and then malnutrition, and then malnutrition because of which, and some developmental disorders as well. And they have found, modeling has shown that economic impact on the GDP can decrease by 1.3% with large amounts of malaria in the country. The best way to diagnose it today is, blood film microscopy is still the gold standard, and then you have antibody-based rapid diagnostic tests, which are very useful to also detect malaria. I'm not going to go over the cycle because most of you, being infectious disease fellows and physicians, are already aware, but we know that when the mosquito bites and you have the sporozoites that go into the liver, they infect a hepatocyte. You have the liver schizons, which are after some time will break open, and you will have the merozoites, which will then will infect, and some of the which will infect the red blood cells, and then some of those merozoites can also become into gametocytes, and that's how the sexual stage occurs. And the cycle is then complete when a mosquito then bites a human host. So there's been a lot of work in terms of malaria prevention and control, and we also have a very good group that is involved in drug development at the College of Public Health as well. It is possible to eliminate malaria. It's not that it is not possible. We have countries like Maldives, Tunisia, and UAE that have eliminated malaria. The current control strategies in Africa mainly are providing long-lasting insecticidal nets. That is the most important strategy that has been used, along with indoor residual spraying. So those are the 2 important strategies. And if you look at LLINs, you will find that all-cause mortality can decrease by 20%, as well as child mortality. In neonates, about 8%, and 37% in 1 to 4-year-olds. This was a study that was done in Zambia. One of the issues with using insecticide nets, as we all know, is not being adherent. Just like for medications and everything else. So the end user adherence is a huge problem. And the second other issue is also resistance to pyrethroids, which are used in insecticidal treated nets. Indoor residual spraying as well is something that is another strategy that is used. So to prevent this resistance, they use a rotational use of insecticides. And then they avoid using pyrethroids in the same area where you have insecticide-treated nets. So that is another way to have better results from resistance. Providing intermittent treatment for pregnant women has found to be a great strategy to control malaria in pregnant women. And why should you control malaria in pregnant women? Because placental transfer is common, and to prevent placental transfer, as well as it has been found that it reduces infant malaria by 60%, as well as anemia by 50%. You also have intermittent presumptive treatment for infants. One other strategy that they have found, instead of doing it intermittently, is also to do it seasonally, because there is a rainy season which is around 4 months. So they found providing intermittent treatment by just in that season for 4 months can significantly also reduce malaria in children. Right. So that is a good question. Those are some of the issues that they face, because you don't have regular sustaining funding for treatment, and so you cannot. So these are interventions which they show can have an impact. Everybody is not receiving it obvious, because we still have such a problem. So unfortunately, if you have interventions that would work, but we have to find a way to find funding to continue those interventions. The vaccine trial has proved to be very beneficial, and there is hope that with this vaccine we will reduce malaria significantly. It's not going to reduce all of the malaria, but the RTS phase 3 trial found 50% efficacy among 5 to 17 month old, and 30% efficacy for clinical malaria, as well as 26% for severe malaria among 6 to 12 week infants. And there's a new trial by Scenaria which found 100% protection, but this was among adult volunteers. So this was a successful malaria control program where it's very important you do surveillance even of the mosquito vector, right? So you want to check the density and the types of mosquito larvae, and that is what they do, is one of the strategies that they use to control the vector. In 2013, 136 million insecticidal nets were given to endemic countries. And this study showed that 64% of suspected malaria cases globally received a rapid diagnostic test in 2012, and 61% in Africa. So if you...
Those rapid diagnostic tests are that good?
It's not the gold standard, but at least it can, in places like this where you can't do blood film microscopy, you don't have enough infrastructure to do that and have a lot of workers to do that, then the rapid diagnostic test is much easier to use in the field. So, and in India they use slide examinations. So 120 million slide examinations were done. This is a child with cerebral malaria on the left, and on the right, when they provide the insecticidal bed nets, they finger mark the child under 5. This is again children suffering from malaria, and the first line of treatment for falciparum malaria is artesunate. So that is what is the first line regimen that is provided to children. So in 2012, 135 million, they estimated 135 million were protected by endoresidual spraying. But that was just 4% of the population which is at risk. So there's a large number that is not covered, large number of households that are not covered. So artemisinin-based combination therapies are supposed to be the best right now for controlling malaria, particularly falciparum malaria. And unfortunately, there have also been resistance issues with this in Cambodia and some of those countries in that area in Southeast Asia. There's also Plasmodium vivax resistance that we are aware of with chloroquine. One of the challenges that in treatment and control is also trying to provide treatment to patients. And so they found that training local drugstore owners to provide appropriate treatment would be helpful within 24 hours of 24 hours of symptoms, as well as providing user-friendly packaging of blister packs so that people can read that very easily and are able to use the medicines accordingly, and providing suppositories of artesunate. There are some new drugs that are already available in the pipeline which seem to might have a great impact, and we are still waiting for some of those trials to come out. And the last disease I'm going to talk about is HIV/AIDS. As you know, 3.2 million children are estimated to be living with, less than 15 years are estimated to be living with HIV. And 3 decades later, you will see there are about 190,000 deaths among children less than 15 years, and 240,000 newly infected. These are mainly children, newborns that are infected. 199,000 through mother-to-child transmission. And if without ART, 50% of children with HIV will die before the age of 2. So ART, antiretroviral therapy, is very important. And studies have shown in 2008, a study showed that before the 12th week of life, if you provide children with antiretroviral therapy, it can decrease mortality by 75% and decrease HIV progression by 76%. And yet only 23% of HIV positive children are receiving ART currently. One of the other challenges is there are fewer antiretrovirals that are produced for children or are being developed or manufactured for children. And unfortunately, only children are a third less likely than adults to receive ART. So this is a nice graph which shows you how many adults are receiving ART compared to children. So in some of the cases where there are a lot of children that are receiving, but when you look above, like in Chad, Cameroon, DRC, Ethiopia, Ghana, all of them, you have adults receiving ART more than children are. So to prevent children from getting HIV, we have to also look at how many women are being tested. So only 44% of women in low and middle income countries received an HIV test. And while that increased from 29% in 2009, it is still pretty low. So you have 56% of women not receiving an HIV test. In terms of ART coverage, we have only 68% of women that are receiving ART right now. And as most of us are already, or you might be already aware, that ART is, according to the new WHO guidelines, all pregnant women are eligible for ART now. So there should be really universal access for pregnant women all over the world, but that is not happening. While 16% of children were only newly infected in 2013, which is definitely less than a quarter in 2009, it's still a pretty large number. One other challenge has been that the HIV PCR test that is needed, children cannot be tested for HIV. Dr. Montero says, right, with the regular tests that we do for HIV, and in terms of that, that test is not easily, PCR facilities are not available in most parts of the developing world. And so since this has created a huge problem in terms of detecting children with HIV. It has also been clearly shown that unintended pregnancies can prevent mother-to-child transmission better than preventing it, providing ART or providing HIV testing and counseling. So one model showed that 21.3% of pediatric infections can be averted if there are family planning services available for women. Currently, there are only 8 low and middle income countries providing universal access to ART for HIV positive people. What is most important, the big mantra right now is towards an AIDS-free generation. That means having no children with AIDS. And for that to happen, we will need interventions also for HIV negative mothers and mothers that are free and to keep them free from HIV, as well as, there are several challenges that would need to be met to increase the number of HIV testing in pregnant women. And if you see that there's a big fear among HIV pregnant women in terms of testing. So, other than fear, it's also sometimes they have to ask their relatives. They might have to ask, in India, it'll be their mother-in-law. You can't do a test unless you ask your husband or your mother-in-law. So those are some of the challenges that have been faced in other countries. In Malawi, they did a program that they have been working with pregnant women, and they found that they need to check with their husbands or their partners. Also that there are no access to services in certain places. In the study in Malawi, they saw that there was no counselor on site at times when they needed to do the HIV testing, as well as, the counselors were so busy because there were too many patients, and they just, some patients missed the opportunity of being counseled and tested for HIV. So there are many issues that need to be met before we can increase the number of women that receive an HIV test. Increasing ART also has its challenges. Increasing access, there are supply issues, as Dr. Montero pointed out a little while ago. Then integrating services, providing ART when women come for their ANC visits. So when you come for your antenatal visits, that's when you can provide ART as well. But sometimes your ART center is not with your maternal and child health center. So you have two different places that people have to go to. So if pregnant women don't have a one-stop shop for all their care, you're going to find it challenging to provide coverage and have women come in for their treatment. So in order to improve adherence, some of those issues would have to be considered as well. And reducing stigma, which is also a big issue, continues to be a big issue in most communities. In terms of trying to improve diagnosis and treatment for HIV-exposed children, early PCR testing and rapid referral is very important. Also trying to increase the number of ARVs. I think the world has to get together to find a way to increase the number of ARVs for children, as well as developing optimized regimens. They found that the regimens are not optimized for children. And also prioritize it's really hard for me to say this, but I'm going to try. It's cotrimoxazole prophylaxis. And that is, I think, what is like Bactrim and Septran that we give normally to adults, but that is something that has not been given to children, and that can prevent many of the other co-infections. So resolving supply issues and then preventing loss to follow-up as well as increasing adherence can also help in improving treatment for HIV-exposed children, as well as decreasing mortality due to HIV. So before I wind up, I just wanted to quickly talk about some factors that have prevented or rather have resulted in the current issues that we have with infectious disease control, because most of the programs were vertically based, and you had single programs that were prevented and controlled and didn't integrate services. So it was only in 1995 they came up with a strategy to integrate all childhood illnesses, and as part of that you provided a lot of different interventions at one time, and you made sure that you trained all these community health care workers to ensure that children were provided as well as mothers were provided services at the same time. So the strategy included, early and accurate assessment of the child, providing vitamin A, providing breastfeeding, complementary feeding, as well as immunizations. And then you had all the antibiotics for the infectious diseases, as well as oral rehydration, anti-malarials, treatment for HIV/AIDS, and also trying to promote care-seeking behavior. So there were different strategies that were all integrated within one whole plan for children. And about 75% of countries that require interventions to reduce child mortality are currently using IMCI. So the countdown report really was focusing on trying to reduce in these 75 countries to reduce the mortality so that they could bring it down to 2/3. And they found that stunting was one of the major issues in these children. And this slide shows you the number of interventions that each country, you can see the percentage of coverage for each of these interventions for the different countdown countries. So I'm going to end with that. There are several resources that are available. And if you have any questions, I know we are gone over time. So if you have any questions, feel free to email me or we can discuss. Thank you for your attention.